Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.in and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the urinary symptoms and investigations. Every system has some symptoms to point out to a particular disease. Likewise, urinary system has three symptoms. A variable triple LAS accompany most of the urinary affections. Pain, renal pain. It is usually a dull pain situated in the costovertebral angle, also in the upper and outer quadrant of abdomen. Ureteric pain. It is a well-known colic pain passing from loin to the groin. Vesical pain. It may be a slight suprapubic discomfort to a strangury and is agonizing pain referred to the external urinary meatus, accompanied by an intense desire to pass urine, but only few drops of blood-stained urine is expelled. Prostatic and seminal vesicular pain. The pain is deep-seated in rectum, referred to the perineum or suprapubic region or one or both iliac fossa. Urethral pain. It is scalding and occurs during micturition. Frequency. In prostatic disease, the patient has to rise at night to micturate. Hematuria. Hematuria means the blood in the urine, however transient, is a symptom that must never be ignored. Painless hematuria is a herald of a new growth in some part of the urinary tract that needs a complete urinary investigation, should be implemented immediately. If the hematuria is painful, the patient demands relief followed by investigation. Causes of kidney stone in the kidney, infarct, injury, tuberculous ulcer, glomerulonephritis, purpura, anticoagulants usage, papilloma of pelvis, neoplasm of kidney. Ureteric causes: stone in the ureter and neoplasm of ureter. Urinary bladder causes: stone, neoplasm, tuberculosis, cystitis and bilharziosis. Prostatic causes: benign prostatic enlargement, malignancy and prostatitis. Urethral causes: stone in the urethra, papilloma, carcinoma and rupture of urethra. Investigations of urinary tract: general physical examination, heart, blood pressure, chest, hemoglobin estimation are important. Anemia is an aggravating condition to uremia. Urine examination: midstream urine is examined for chemical, bacteriological and microscopic examination. Renal function tests: structural damage can occur before functional damage becomes apparent. Kidney function can be impaired in three ways. Renal plasma flow may be reduced, glomeruli may be damaged, or the function of the tubules may be impaired. The essential hypertension, the chief fault lies in the renal plasma flow. In glomerulonephritis, the main effect is reduction in glomerular filtration rate. In pyelonephritis, the brunt falls on the tubular function. In back pressure due to obstruction, all becomes impaired. Range of specific gravity. Concentration dilution test. The power of kidneys to concentrate and dilute urine is a good test for their functional integrity. Fluid is withheld for 12 hours overnight. The specific gravity of the first two morning specimens should reach 1.020. A specific gravity of 0.025 in a urine free of protein indicates good renal function. 2.2 pints, that is 1.2 liters of water is given by mouth within 4 hours. The specific gravity of 1.010 presumptive of impaired distal renal tubules. Blood urea, non-protein nitrogen. Normal range is 20 to 40 milligrams per 100 ml of blood. A reading above 40 is a suspicion that more than 50 is indicative that the kidney function is impaired by at least 50%. Creatinine clearance test. It is a convenient method of measuring the glomerular filtration rate. One sample of blood and accurately timed collection of urine for a period of 24 hours are all that is required. The estimation of creatinine in each enables a clearance to be arrived at. The normal clearance is between 80 and 120 ml per minute. It decreases in old age. Intravenous pylography, IVP. Strictly speaking, it is the urography as more than kidney pelvis is examined. It is a contrast X-ray with the medium sodium diatrizone, otherwise called hypac, is used. It is mainly secreted by proximal tubules. Preparation. A mild vegetable aperient is given on 2 evenings preceding the examination. No fluid should be taken for 8 hours before the investigation, and the patient is instructed to empty the bladder just before the injection. Technique. Keeping the patient in recumbent position, 20 to 40 ml of the sodium diatriozoate or hypac is injected in the vein of the arm. None of the solution must escape into the tissues around the vein, as it is irritant. If the kidneys are functioning, the medium appears simultaneously in the calyces and pelvis of both kidneys. 2 minutes later, X-ray films are exposed at 5, 10, 15 and 25 minutes. Compression applied to the abdomen by a strap enhances the clarity of the pylograph as it delays the emptying of the renal pelvis. The concentration reaches maximum in 30 minutes. After 25 minutes, the film in the erect posture is valuable to demonstrate the mobility of the kidneys, to vascularize the uterus. Normally visible excretion is completed in 1.5 hours. Later, the radiograph shows the bladder filled with medium. In order to display the termination of ureters, the patient should micturate immediately before final radiograph. The amount of residual urine in the bladder, if any, can also be demonstrated in this way. If the pelvis and calyces fails to empty within normal limits, next radiographs are taken at half-an-hourly intervals. Infusion pyelogram. If the blood urea of the patient is more than 100 to 200 milligrams percent and infusion of 50% hypac, 1 ml per lb in an equal volume of normal saline over a period of 10 minutes will produce useful urogram. Contraindications of IVP. When the renal function is poor, secretion is insufficient to produce a reasonable film. Idiosyncrasy. Idiosyncrasy to iodine must be excluded by a small preliminary test dose with 1 ml IV. History of asthma and other allergic conditions should be kept in mind. In untoward effects developed during injection, stop the injection at once. Oxygen is given to control anoxia. and antihypertensives to control hypertension, dextrose saline, if necessary, to be followed by dextrone to counter the shock. Important antidotes are antisan 100 milligrams intravenously or hydrocortisone 100 milligrams intravenously. Instrumental examination on the urinary organs. Anesthesia for the instrumental examination of urinary organs. Local anesthesia of the urethra is a must. In males, if prepuce is present, it is retracted smegma removed by washing with soap and water, followed by swabbing with mild antiseptic solution. Lidocyasin 1% lignocaine with 0.25% chlorhexidine gluconate as a local antiseptic in a jelly base is the safest. About 15 ml is squeezed into the urethra and retained for 5 minutes with the aid of a phenyl clamp placed proximal to the glands. In females, the vulva is washed with soap followed by swabbing with a mild antiseptic solution. In labia minora are held apart and the local anesthetic jelly is injected into the urethra. Boginage. After aseptic preparations, dilatation is carried out with bogies of an increasing size. Strictures of small caliber should be dilated for twice a week first. The types of bogies are gum elastic bogies, filiform bogies. Catheterization. With the due antiseptic precautions, it is performed with the types of catheters: plastic catheter, Polis catheter, and suprapubic catheter. Cystoscopy. The cystoscopy is used to view the interior of the bladder and to observe the ureteric orifices. In adults, 7 ml of 0.4% solution of indigo caramine injected intravenously. The excretion of the dye down the ureters can be watched. Normally, it should appear within 4 or 5 minutes. Delay of excretion of the dye on the side is indicative of unilateral obstruction or disease, but delay on both sides suggests bilateral renal impairment. By employing a catheterizing cystoscope, ureteric catheters can be passed on each ureter, and specimens of each ureter and specimens of urine from each kidney are collected. By analyzing such specimens, much information is obtained. Retrograde pylography. Instrumental pylography. It is performed when still clear definition is required, like suspected renal neoplasm or early tuberculosis, or to collect urine from each kidney separately for differential function tests. The ureters are catheterized and the patient is transferred to the radiological table. A plain radiograph is taken and developed before injecting the medium to ensure that the catheters are not too advanced. A sterile 12.5% solution of sodium iodide or 20% solution of iodoxyl can be employed. A pylograph syringe which fits any ureteric catheter is filled with 10 ml of solution, and injection is made of the catheter slowly. If pain is accompanied of the injection is stopped. The initial film after 4 ml have been injected will outline a normal pelvis. If a large hydronephrosis is present, more medium is required to have a clear definition. In this method, it is possible to inject the pelvis of both kidneys at the same time. But in case of poor renal function, it is necessary to make each examination independently. After completion, as much of the medium as possible is aspirated from the renal pelvis. Cystoscopy. It is three types of excretory cystoscopy, retrograde cystoscopy and micturating cystoscopy. Excretory cystoscopy. The cystographs which accompany the later films of excretory pyelography may not be sufficiently dense to give a clear delineation of pathological condition in the bladder. Retrograde cystoscopy. It is used to confirm the presence and dimensions of a vesical diverticulum. A rubber catheter is passed and the urine in the bladder is evacuated. If a diverticulum is suspected, the patient is made to lie on the face to ease the drainage of the urine from the diverticulum. A plain radiograph is taken to exclude the calculus in the diverticulum. Now the bladder is filled with medium till the patient feels desire to micturate. The medium preferred is 25% solution of iodoxil. A radiograph is taken with the full bladder, and after the bladder is empty, if the diverticulum is present, it will remain full of medium after the medium has been left the main cavity. The extent of a very large neoplasm of bladder sometimes is demonstrated by cystoscopy than normal cystoscopy. Micturating cystoscopy. This is best performed with an X-ray image intensifier. The function of the bladder, neck and the presence of ureteric reflux of urine can be observed on a monitoring screen as the patient empties the bladder. Urethral Scopy. It is of two types, anterior ureteroscopy and posterior ureteroscopy. Anterior ureteroscopy. It is used in case of urethral stricture. It is conducted by air inflation of the urethra. Posterior ureteroscopy. It is helpful in inspection of prostatic and membranous urethra. It is carried out with an irrigating urethroskop. The most notable normal spectacle of posterior ureteroscopy is the virimonatum, which presents as an eminence on the floor of the prostatic urethra. On the summit of this projection is the sinus specularis. Into the sinus specularis open the ejaculatory ducts. The orifices of the ducts can sometimes be seen. The virimonatum is reddened and enlarged in case of chronic vesiculitis. In case of chronic prostatitis, one or more of the numerous prostatic ducts, which normally are difficult to visualize, may be seen exuding pus. When the prostate is enlarged, it can be seen as a bulging of the floor and lateral walls of the urethra in the vicinity of the internal urinary meatus. Urethropy. It is useful for gaining information about the length of the urethral stricture of dilatation or diverticulum formation above the stricture or of failure of the medium to pass the stricture. It is also reveals the dilated prostatic ducts in chronic prostatitis and tuberculous prostatitis. It is valuable to determine the presence of contraction of the bladder neck. The contraindication is the urethral hemorrhage. The medium used must be chosen with great care, as if there is a breach in urethral mucosa. It enters the circulation. Mostly used medium is Umbrodil viscous V. It is a jelly which is squeezed from a tube into the butt end of the urethral syringe. It contains a local anesthetic lignocaine. The injection is made satisfactorily by employing Knutson's apparatus, which has a phenyl clamp attached. Renal arteriography. Renal arteriography can provide information to visualize the renal architecture. Is of diagnostic value in conditions like hypertension, renal neoplasm, renal cyst, chronic pyelonephritis, aneurysm of renal artery. There are two methods of performing renal arteriography. Translumbar arteriography. It is carried out under general anesthesia. A needle is passed into the abdominal aorta just above the renal arteries at the level of L1. The contrast medium is injected and 4 films are taken in succession. To minimize accidents, a small quantity of medium is injected and a film taken to ensure that the needle is in correct position. Retrograde arteriography. A Seldinger's needle is used. The needle is passed into the femoral artery. Stillet is removed. A spiral guide wire with a supple tip is passed into the artery and the needle is removed. The artery is compressed to avoid bleeding. Polythene tubing is threaded onto the ladder end, so guided through the skin and urethral puncture into the artery. The polythene tube is advanced to the desired level. A small quantity of hypaque injected to render it opaque to X-rays. The medium is then injected. Selective renal arteriography can be achieved by using a hooked polythene tube and guided it into the renal artery. In any method, not more than 30 ml of hypaque should be injected to minimize the accidents. The dangers of the procedure are tubular necrosis, paraplegia, elevation of plaque, of atheroma, and dissection of aortic valves. Perineal insufflation of oxygen. The debinillate a renal or adrenal swelling. Renal tomography. It is sometimes used in combination with other radiographic procedures, as it can help in doubtful cases of differentiate between tumors and cysts. That's all about the symptoms and investigations of urinary tract, and in the next video I will discuss about some other disease. Thank you.